Morning, Good morning, everyone. I hope you can all hear me. It's my pleasure this morning to introduce Dr. Jamie McCabe. When those of you who've given grand rounds at the University of Washington know one of the things the organizers do immediately when they're preparing for grand rounds is ask the speaker who they would like to introduce them. And in this case, Jamie responded, anyone non-comatose would do. So I am very honored that the staff would immediately think of me as the most non-comatose person in the division. So honored to do this introduction. We recruited Jamie back in 2000 and almost 14, but in the fall of 2013. And he's really had a meteoric rise academically since then. He is currently on track to be promoted to professor in 2022. His publication list is longer than mine. He talks around the world on various structural issues. I think the only thing I ever had doubts about with Jamie was his, sort of ability to mentor. And that was resolved back in 2015. And so those of you who are football fans know back in 2015, Jamie was an avid Patriots fan back when they used to be good. The entire, when they were in the Super Bowl with the Seahawks, the city was awash with neon green. And Jamie suited up his daughter in a Patriots jersey and sent her to elementary school, or at least that's what the legend is. I said, that is a mentor and father who can build resilience and so he's done a fabulous job since. He's going to give us a talk this morning on their tricuspid valve. Sorry, I forgot to text you back. Thank you, Jamie. I look forward to the talk.
Thank you, Rob. Appreciate it. All right. So we are going to spend the next 50 minutes talking about tricuspid valve, kind of a sort of survey of the valve, if you will, with an eye, of course, towards therapy, because that is largely where I live. But we need to back up for a second and talk a little bit more about the value of this valve, because I think that's where things get really confusing. So let's just start there. Here are my disclosures. So what's it all worth? We've all ignored the tricuspid valve plenty, and that's true because no one in the audience here has ever sort of declined to send someone forward for major cardiovascular surgery or abdominal surgery because of their severe TR, and or no one's ever said, well, we would love to have you have this brain surgery, but boy, we got to fix this tricuspid regurgitation first. That just doesn't happen. It's never happened. And so on that basis, I think we've all just kind of been like, yeah, okay, you have it, whatever, let's move along. And that to me has been one of the real fundamental questions as we get sort of deeper and deeper into the web of treatment, is just how valuable is it to treat it? The burden of TR is, I think, pretty well established, and I am not suggesting that Olmsted County in Minneapolis or in Minnesota is representative of the country. It's clearly not. However, in this county, the prevalence of moderate or greater tricuspid regurgitation is about 0.55%. So if you look at that if you extrapolate that to the U.S. Census, that would suggest there's about 1.8 million people in the United States with substantial tricuspid regurgitation. And one of the things that's kind of interesting about that number is that if you look at the number of isolated tricuspid valve surgeries performed over a 10-year period in the United States, it's about 5,000, which represents 0.3% of all patients with moderate or greater tricuspid regurgitation. Now, surgeons aren't stupid. They're they're crafty. And so should we interpret that as suggesting that the valve just doesn't rise to the level of requiring therapy? It's hard to know, but certainly that's been the calculus over the last few decades. And if you go back even further, A. Brunwald, not the one you might think of all the time, clearly didn't find the tricuspid valve important. This is from the late 60s, just kind of suggesting that functional tricuspid regurgitation will resolve. You don't even need to deal with it during open heart surgery. I think that's largely, we've moved away from this thought process, but it is sort of a historical context. And then there's this guy. Who's this? Nobody can answer on Zoom anymore. This is Francis Fontan. He didn't always think the tricuspid valve was important. In fact, he didn't even necessarily believe that the pre-lung heart was important. And now you could argue that these are congenital patients. They're different. Their adaptive responses are wildly different, and I'm not saying they're not. But certainly this is sort of the types of information we've been assimilating into our cardiovascular practice over the last number of years. And it's hard to think about a Fontan and simultaneously think tricuspid valve is important unto itself. And I agree. It is hard to understand. And then let's take it a step further. Valvectomy. And I got to thank Eric Krieger for pointing this out to me, because I had never heard of this before. In folks with infective endocarditis of the tricuspid valve, largely intravenous drug abusers, it's a trial of opening the heart, cutting out the valve, throwing it away, and then closing the patient back up, versus putting in a prosthetic valve or doing some kind of repair. Valvectomy. That's mind-blowing in many ways, because you're saying not only is the tricuspid valve not important enough on a day-to-day basis, but you can tolerate going through a major cardiothoracic surgery coming off the heart-lung machine with no tricuspid valve, like the most adverse circumstance, and yet they theoretically can survive. And this isn't just one whack-a-mole surgeon. There's a whole bunch of them. This is a meta-analysis. None of these trials are any good, by the way. Don't sort of infer anything from the actual outcomes of the trial. The point is simply that they're doing that. This is being done, right? Tricuspid valves are being chopped out of people's body, thrown away, and the chest is being closed. And meanwhile, I'm here telling you that, let's pay attention to the tricuspid valve. Those are really at odds. And there's a lot of conflict in that. And this, by the way, is not, this stuff isn't coming out like, oh, remember that time we were thinking about voting for Ross Perot in the mid 80s, and also we published on valvectomy? No, this is 2 years ago, 2019, this meta-analysis was published. So this is contemporary, and it's not done broadly, I don't think, but nevertheless, really kind of fundamental bits of information. So you say to yourself, like, why are we here, right? I mean, next month I'm going to talk to you about appendix filters. It's going to be so much fun, and I got a whole nother list of exciting ground rounds coming up. So it is, I think, fundamentally really hard to place the value of tricuspid regurgitation into the context of Fontans and valvectomies and a legacy of not really treating the tricuspid valve. Nevertheless, then there are data like these, right? I mean, there's obviously a reason we're here. And this is 33,000 patients from Tel Aviv. Index echocardiogram demonstrates moderate or greater, index echocardiogram demonstrates any tricuspid regurgitation. And what you see essentially is a dose response curve, right? Severe tricuspid regurgitation, the bottom line, those patients do much worse over a 5-year time horizon than folks with none or mild tricuspid regurgitation. And in this case, they adjusted for a whole bunch of features, including left heart features and even TAPSE. I mean, they're all echo-based aspects that were adjusted for, but you still have a hazard ratio of almost 2 between the association of severe tricuspid regurgitation and mortality. So it's not for nothing. However, these are also patients where, you know, a bunch of them were, a bunch of the echoes were performed during index hospitalization. And, you know, you could imagine that, okay, well, maybe some of these people come in with septic shock and they get 12 liters of fluid and now they're anosarchic and they've got TR, and should it really surprise you that they die? I mean, or that they die more commonly than someone who doesn't have an ATR? Perhaps not, right? I mean, maybe this is just a bellwether valve. And I think that is certainly a possibility. The authors actually acknowledged, or at least sort of considered this, and they split the population into hospitalized patients during index echocardiogram and ambulatory patients. And in the crude hazard ratios, the unadjusted hazard ratios, first off, you see that the kind of dose response thing remains in place. But what's interesting is that among your ambulatory patients, these are folks who just are walking in off the street or you'd see in clinic, they actually had a larger hazard ratio association between mortality and severe tricuspid regurgitation. Perhaps not surprising, because the hospitalized patients have just more going on, and therefore the magnitude of effect from tricuspid regurgitation is perhaps not as powerful. But just sort of emphasizes this idea that clearly people with TR, severe TR, don't do well. Doesn't necessarily tell you whether or not it is the tricuspid regurgitation that is driving that. But we know, just kind of on a population basis, it's not a good sign. You don't wish this on people. And one of the confusing aspects of this is just this sort of classic construct where you have, you know, RV volume overload, RV dysfunction, progressive TR leads to more volume overload, leads to dysfunction, and it's a cycle. And so for functional tricuspid regurgitation, or secondary, whatever you want to call it, which is the vast majority of tricuspid regurgitation, it's hard to peel away the tricuspid regurgitation from the RV dysfunction. And it's sort of a classic chicken and egg sort of argument. And that's made somewhat worse by the fact that there are multiple morphologies of tricuspid regurgitation. They sort of fall into 3 broad categories. The first being primary tricuspid regurgitation, where it's a leaflet problem, and the ventricle and the atria are sort of, at least at the initiation, okay. There's secondary or functional tricuspid regurgitation, where it tends to be considered a right ventricular problem when you get RV dilation and therefore annular dilation leading to tricuspid regurgitation. And then in this case, the authors call the third category isolated TR. I think a lot of folks in this space call it atrial functional tricuspid regurgitation. This is the one most often associated with atrial fibrillation. And the idea here being that the atrium dilates and therefore dilates the annulus. So 3 different sort of pathologic mechanisms for tricuspid regurgitation, all somewhat, you know, different from one another. And then there are, of course, multiple etiologies for TR. And if you look at this Spanish data, 35,000 echocardiograms, the vast majority of TR is secondary, 93%, give or take. And if you kind of go to the left there and look at the secondary TR population, most of those are related to mitral or aortic valve disease, and tricuspid regurgitation being kind of a downstream consequence. However, if you look at the primary population of TR, the vast majority of those, at least in the modern day, appear to be related to implantable cardiovascular devices, pacemaker leads, defibrillators, and so forth. This is not to impugn anybody, but I think that this is actually a really fascinating group of patients, because it sort of speaks to this chicken and egg thing, right? These are patients where the advent of tricuspid regurgitation is not a cult. You put a pacemaker lead in And then essentially immediately afterwards, you have new tricuspid regurgitation where the pathology starts at the valve, theoretically. I mean, some of these patients might already have pre-existing RV dysfunction or pre-existing large right atria, pre-existing AFib, of course. But generally speaking, in this particular study, they looked at patients who had an echo predating their implantable device and then post-dating their implantable device, looking for new TR. I mean, these are people where you know that the nidus, that the fertilized egg, which is the start, was the pacemaker lead and the tricuspid valve. And it turned out that in this case, almost 40% of implantable devices led to moderate or greater tricuspid regurgitation. I don't think that's necessarily true everywhere. I don't know if they're electrophysiologists, who knows, but what you can see, and I pared down this table because it was sort of so large, it was unreadable. I pared it down to a couple of echocardiographic factors in regards to right atrial and right ventricular size and function and left ventricular size and function. What they saw essentially was that people who had new TR ended up with increased end-diastolic, RV end-diastolic areas. They ended up with increased right atrial diameters. They ended up with increased pulmonary pressures. So just all consequences of RV volume overload relative to that tricuspid regurgitation. And lo and behold, what they saw was that if you had new moderate or greater tricuspid regurgitation, sort of as the nidus for your problem, you ended up, after a certain amount of kind of latency period, I guess, the mortality curve started to spread. It's 240 patients, it's not a million people, but you could see that lead-induced TR did sort of start to create some problems. Now, perhaps those are patients, if you're going to have lead-induced tricuspid regurgitation, maybe those are patients who have some kind of substrate that is less good. It's possible that the valve itself is, this is just the straw that broke the back, so to speak. But inferentially, it does suggest that sort of introducing tricuspid regurgitation creates a scenario of RV enlargement, RA enlargement, pulmonary hypertension, and that in combination then leads to potential mortality and also hospitalization and mortality as a combined outcome. So just sort of some kind of interesting population to try and break through this chicken and egg sort of discussion. All right, let's move along here for a second to guidelines and grading. So first off, staging of tricuspid regurgitation is obviously paramount. These are from the updated valvular guidelines of the American Cardiology and the American Heart Association. Largely, TR grading has been, I think, somewhat qualitative over time. It's, people talk about interventional cardiologists having the oculostenotic reflex. I'm not sure that echo folks don't have a bit of an oculopixel reflex. There's probably a better way to say that, but there has been an emphasis in recent guidelines to try and make quantitative or at least semi-quantitative kind of criteria around the severity of tricuspid regurgitation. In these guidelines, they're broken down essentially into severe and not severe tricuspid regurgitation, where not severe falls into this progressive category, that's stage B, where you have a vena contracta less than 0.7 and an ERO less than 0.4 centimeters squared, and no signs or symptoms. Then you get into stage C, that's severe, where your ERO is greater than 0.4, or your vena contracta is greater than 0.7, or other sort of factors. But you don't necessarily have signs and symptoms. And that is actually a hard thing to distinguish. As someone who's increasingly seeing patients with tricuspid valve, with tricuspid regurgitation in clinic, I can tell you for sure that if all you're looking for is abdominal bloating and lower extremity edema, A lot of these patients will not have those signs and symptoms. And then stage D is similar to stage C, except with overt signs, symptoms, relative like dyspnea on exertion, fatigue, ascites, edema, etc. Okay. Now, one thing that's interesting is that there has been a push to actually, in the context of quantitating TR, there has been a push to expand the number or the stages of severity from mild, moderate, severe to mild, moderate, severe, massive, torrential. And essentially they took these EROs that kind of, EROAs rather, that changed by 20 millimeters per grade and just kept going. So that you see massive is 60 to 80 millimeters, give or take, of EROA, and then 80 and above is torrential. And this, those aren't playing, but in this case, this actually came about from an interventional trial that was published in 2017 called the SCOUT trial. This device is DOA, so you don't need to know about the actual pledgeted suture system, but an interesting thing that came out of this analysis published in JACC was that this pledget system could, on average, reduce the EROA by 22 millimeters squared. So that's a full grade by the standard grading system. And that consequently led to actual meaningful improvements, like 12 to 13 points of KCCQ 36 analysis. So you saw patient benefit and you saw EROA reduction, but these people started with an EROA of 85 millimeters, right? And so thus the reduction in treatment was from severe to severe, because 80, over 60 is severe. So, so they were like, well, wait a minute, we're getting reductions, we're seeing clinical outcomes that are improvements. I'm sure they weren't, and patients weren't like running marathons, but still the grading system would suggest that we did sort of nothing. And that was what was the impetus behind trying to create this extended categorization into massive intervention. It's all about just trying to justify interventional cardiologists' work. So it makes sense. Just kidding. So there are, in addition to just severity, there are a series of factors that are important prognostically for patients with tricuspid regurgitation. And so for those of you seeing patients in clinic with severe tricuspid regurgitation, the things that suggest that patients do worse are basically all about RV dysfunction, which is not surprising. So TAPSE, fractional area change, and longitudinal strain. I'm not going to go into this too much because I will reveal some of my ignorance around echocardiograms as you get into the more refined features, and we can't have that. But suffice it to say that longitudinal strain above and beyond TAPSE and above and beyond fractional area change appeared in this particular analysis to be the most determinant of poor patient outcomes and mortality, basically, over the long term. And so that was what the authors suggest that should be an point of emphasis in patients with severe TR. Now, I'll say that not incorporated in this trial, but incorporated in the guidelines and in other trials, an annular diameter greater than 40 millimeters is also considered a bad prognostic sign and something that you might want to keep an eye on as well. In fact, in the guidelines, as we'll see here in a second, they do specifically point to that 40 millimeter threshold. So what do the guidelines say about medical therapy? Well, they don't say much, really. Both of these are 2A expert opinions. The diuretics may be useful, and if it's secondary, treat the underlying problem. That's essentially it in a nutshell. Now, I don't mean to be dismissive of diuretics. We've all seen, if you see these patients in clinic or in the CCU setting, all of us have seen that aggressive diuresis and careful management can completely abrogate severe TR. I mean, you can go to almost nothing in certain populations. Of course, at a certain point in the kind of natural history of tricuspid regurgitation, it does become somewhat refractory to diuretics, but certainly early on, that is, I think, the right move, though there are no mortality data there. I'm not going to spend much time on the European guidelines. The updated valve guidelines there came out in 2017. They dedicated one whole page to tricuspid regurgitation out of 52. The other 51 pages given to the other valve pathologies. So not much to say here, but it is worth pointing out that second row, which stands alone, because it is not consistent with the American guidelines, and it essentially says, surgery in symptomatic patients with isolated primary TR without RV dysfunction is class 1. And I'm going to show you the surgical data, and I don't know how they came to a class 1 indication here, but they did. So that is worth it just pointing out. On the American AHA-ACC guidelines, the only class 1 indication is to treat severe tricuspid regurgitation in the context of left-sided valvular surgery. There is unfortunately not a single lick of randomized trial data in this space. It's really, I love my surgical colleagues. They had a 60-year head start and nobody could produce a single randomized trial. It's kind of frustrating because we would all know a lot more if that existed. The other guidelines here are all 2A and sort of somewhat cautious just based on the level of evidence available, but progressive TR, patients with right-sided heart failure and severe TR can be considered, etc. You can read them, but a little wishy-washy, and for good reason. There's just not a huge data, there's not a lot of data to base these on, or at least not a lot of great data. Okay, so let's talk about surgical treatment. What is happening there? I think a lot of us have it in our heads that surgery for tricuspid valve regurgitation isn't great, but why is that? What do those data look like? I had never really dug into it before. I just had that general sense that that's something to consider. So most of this comes from billing data, and so we need to acknowledge that right up front because billing data has its limitations. This is from Medicare billing data from my good friend Bobby A at Beth Israel and his group. So what they found, 5,000 total surgeries over 11 years at 800 sites. So if you do the math on that, as you can see kind of on the bottom right there, that's an average of just over a half a tricuspid valve surgery per year per center over the time. And in fact, less than 1% of all hospitals did more than 5 isolated tricuspid valve surgeries per year. So this surgery is just not being done, first off. And hard to be good at something if you're not doing it, for one. But for two, the penetrance of this therapy is really low. And what they found in these data were that there's about a 10% 30-day mortality and a 25 or 24% one-year mortality, slightly better with repair than with replacement. Really prolonged lengths of stay, 15.5 days on average, though data looks a little skewed there with a large disparity. But and then in the hazard ratio, I think the thing that comes up that was most striking to me was that chronic heart failure was a real driver of poor outcomes. I mean, shock should be no surprise, emergent procedure, etc. None of that's a surprise. But chronic heart failure, most of these patients, we've established this, most of these patients are secondary TR, which if they're going to surgery, almost invariably, and this is isolated tricuspid valve surgery, almost invariably means that they have chronic heart failure. Not every one of them, but it's hard to imagine that a lot of these functional or secondary tricuspid regurgitation patients don't. And that was a driver of poor outcomes. So that's worth considering. If you switch from Medicare billing to national inpatient sample data, these are, again, it is basically claims data or billing data. A similar time period, 9 years now. The point of this trial published in JACC a few years ago was to suggest that there was sort of incremental increases over time in the volume of isolated tricuspid valve surgery happening from 2004 to 13. But as you can see, it still ends up being, if you put the red line, which is replacement, and blue, which is repair, together, you're still at 600-700 surgeries across the country per year. And we've started with moderate or greater TRs, 1.8 million people. So sure, it's increasing a little bit, but I mean, it's a drop in the bucket. And in this case, the mortality, the gray line there, was really consistent over time at 8.8%. Mean age of these patients, pretty young, it's 62. And that I was trying to contextualize this data, 8, 9, 10%. And I was thinking, it's just a number, and numbers don't mean much, but or like it's hard to sort of internalize that number. But we're going to do about 400 TAVRs this year, and if we had a 10% mortality, that 40 mortalities, that'd be almost one a week, and that's a lot. So I think I understand why this surgery is not happening very often, and why the penetrance of this therapy is pretty low. If we look at not just isolated tricuspid valve surgery, but rather any cardiothoracic surgery that includes repair or replacement of the tricuspid valve, this is from the SDS database. Now you're getting much bigger numbers, 54,000, of which 85% were concomitant procedures, meaning that some other valve was also being treated. Again, you see about a 10% 30-day mortality, and again, you see congestive heart failure being kind of associated with worse outcomes, as were a series of features related to the complexity of treatment. If it was emergent, if there's multiple reoperations, if you're trying to do CABG, aortic, mitral, tricuspid all in one, things like that. Those were all associated with worse outcomes. But pretty consistent survival data, right? If you look at reoperations specifically for tricuspid regurgitation following a prior left-sided surgery, bunch of small retrospective data. This is not a meta-analysis. This is just a patient-weighted averaging of outcomes, but you again get a 10% mortality for TR reoperation. Take it for what it's worth. It's only a couple hundred patients published over, a 30-year time horizon or 40-year time horizon. And then, one of the things that comes up around surgery in this case is that people say, well, listen, patients with chronic heart failure do worse. There's this negative spiral between volume overload from TR and RV dysfunction and volume overload. Maybe what we need to do, maybe the problem with the surgery here is simply that we're waiting too long, or we're not interceding early enough. This is a really lousy trial, but it's the only data I could find about this concept of early surgical intervention. Like most of the surgical literature here, it started with there was some hypothesis and people saying, well, the problem here is we're just not doing it soon enough. But then when you go to look for any data that about sooner versus later, it's just not there. But Cleveland Clinic, retrospective data looking at isolated tricuspid valve surgeries, you had the majority of patients met a class 1 indication by the ESC criteria. So that is, severe TR with symptoms without RV dysfunction. And then they had a sort of fraction of patients who were quote unquote early intervention. This is not, these labels were retrospectively applied afterwards. So, they are what they are. But they suggested here that people who had this class 1 indication had a 7% mortality. People who didn't yet meet a class 1 indication for surgery, and I don't really specify why they didn't meet this class 1 indication, but those patients had less death, not statistically significant. There was substantial loss to follow-up. So not a lot of information to be gleaned here, but I think there is a question about timing, right? Timing of treatment is an open question, and frankly an unanswered one. So I do think that bears some consideration. Now, interestingly, we've spent the whole time talking about risk and mortality and survivability, but we have not spoken at all about efficacy. And does surgical intervention for the tricuspid valve actually mean something important to your patient, assuming they do survive? And again, no randomized trial data, decades of this happening, even a class 1 indication out of Europe, yet nobody's ever really studied this, which is frustrating. The folks at Mass General, Jason Wasfy and others, did a retrospective analysis looking over a 15-year time period. They screened patients for severe TR on echo, and then carved out those who got treatment, isolated tricuspid valve therapy, plus minus cabbage, but no other valves, versus those who got medical therapy only, and then went through a propensity matching strategy, and ended up with 124 total patients. And the kicker here with this trial is that they adjusted for immortality bias. So what's immortality bias? Well, immortality bias is the idea that if you are starting, if a cohort of patients that you're studying are identified based on a surgery or any treatment, then by definition, those people cannot die between the time they got the treatment and the time they were diagnosed, right? Or vice versa. Between the time they're diagnosed and the time they got their treatment, they 100% have to be alive because you started by culling them based on the treatment. So there may be many patients who got the diagnosis, were scheduled for treatment, and died beforehand, or never made it for one reason or another. And so that immortality bias just says, that duration of time, if you get the treatment, that person was alive between diagnosis and treatment. They had to be. And in the case of this particular trial, that duration of time could be as long as 30 months, multiple years. So if they adjusted for immortality bias, and then moved forward from treatment, they actually could not find a difference in length of life or survivability, I guess, based on whether or not they had medical therapy only or a surgical intervention for isolated tricuspid regurgitation. Now, having a bunch of Harvard kids do a whiz-bang statistical analysis is what gets you to think about, voting for George W. Bush, right? But it is provocative information, and I think in the absence of this is what we get when we don't put together a good randomized clinical trial to actually inform decision making, as we get statistical mumbo jumbo. It's really interesting, and it may mean something, but I don't know. All right, so what about transcatheter therapies? This is what, obviously leading towards this a little bit, since this is my space. And I think there's a lot to digest here. We're going to spend just a few minutes kind of glossing over a lot of it because there's so much that's happened here. But I want to start with this, which is kind of an aggregation of a bunch of trials that have been put together. And so this is published in JACC a couple years ago, and they took basically a series of centers got together and put all of their tricuspid valve treated patients together. And so you had patients who got clip, who got Pascal, both edge-to-edge repair, they got valve replacement, there's space occupiers, annular reduction systems, heterotopic valves, threw them all in one pot and ended up with 470 patients. And then at a couple of the participating centers, they just did consecutive echoes looking for patients who had severe or greater TR, not severe, just severe TR, and that were not treated, and ended up with about 1,200 patients. And then they did propensity matching to arrive at 268 propensity match pairs. So that's a little over 500 patients, right? The propensity matching in this case wasn't actually perfect, in part because, as you may expect, given that these were clinically driven decision-making, this was clinical decision-making around treatment versus not treatment. The patients in the treated group, in general, were sicker. They had more New York Heart Association class, they had more atrial fibrillation, they had worse sort of functional status assessment, but they did the best they could in terms of propensity matching based on age, gender, EF, etc. And when they stratified these patients by treated with a reduction that left them with moderate or less TR, blue line, blue circle, versus treated but somewhat unsuccessfully, black line, black circle, versus not treated at all, medical therapy, whatever that color is, salmon line, salmon circle, you could see actually a really pretty impressive efficacy or in this propensity matched analysis in terms of surviving and avoiding heart failure, hospitalizations, that is. Not overwhelming, but those lines split pretty nicely, actually, particularly the survival free from heart failure, the panel A there, where interestingly, the patients treated who didn't really get a good result actually did sort of behave like you would expect from a control group of sorts, right? They look similar to the medical therapy arm. What I found actually most interesting about this paper is that the time frame we're talking about is 12 months. Right? I mean, let's go back for a second to this Fontan idea and the valvectomy and stuff, and you're thinking, okay, well, how can it be that valvectomy or a Fontan can simultaneously coexist with data that suggests that severe TR patients do very poorly? And then, the way that I had kind of put that together in my own head was to say, well, okay, fine. They do poorly over time, right? And now you're talking to patients in the clinic, and you're like, well, I don't know, maybe we should take care of your tricuspid regurgitation because perhaps over years, it's going to be a problem for you. That may be true here because they maybe were interceding after that over years period, and we just weren't involved earlier. But as it stands, these mortality rates are 12 months, right? This is 1 year data. And look, I mean, those numbers are pretty profound. They're very high. And I just hadn't necessarily completely acknowledged or recognized that in this population of people with severe TR who have symptoms, and maybe it's been going on for a while before they get to you, but the clock is potentially ticking. Look at that medical therapy arm. They're not doing well, right? And when you look at just 1 year mortality from this same paper, the control group, basically 1 out of 3 patients with severe TR that was just medically treated is dead at 1 year. And even in the therapy arm, still 1 out of 5. So, and this is after adjusting for RV dysfunction and AFib and all the things you see down there. So this is a mortal population and a mortal disease state. And I don't know that we for sure know whether or not it's the TR or TR is just the bellwether thing that goes with RV dysfunction. Though in this case, they did try and adjust for that RV dysfunction. But suffice it to say that these folks don't do great. And in fact, if we go back to that Tel Aviv data that I showed you right in the beginning, their 1 year mortality for severe TR was 45%, right? So pretty consistent and frankly striking. mortality outcomes at a year for people with severe TR. Can't tell you that it's from the TR for sure, and I certainly can't tell you that interceding and treating the TR necessarily really changes that curve. But I think that's what we're trying to figure out, and what people are studying right now is not only can we change these curves, but also at what point do we need to step in to change them. And that's why I kind of think that pacemaker data was so interesting, was because you know exactly when they, give or take, you know exactly when that TR happened. And you see that little bit of a lag time that I showed you, right? It was like 12 to 20 months where the mortality curves didn't separate before they did. That's inferential, 100%, I agree with that. But it's interesting. So there's opportunity here, there's no question about it. And I think there's a lot of things that need to be studied and need to be understood. Thankfully, there's a lot of studies going on. Rob just came back on. Am I running late here, Rob? Anyway, I'll just keep going.
No, you're good. I just thought you were.
Suffice it to say, there are a lot of therapies out there. Many of these are already dead on arrival. So we're not going to focus on all of them. I just want you to understand that this space is littered with potential therapies. We're going to focus on just two here. First is tricuspid, edge-to-edge repair, transcatheter edge-to-edge repair. This is large in our center. This has largely been MitraClip, though Pascal, which is an Edwards product, is also being studied in this space. We're not going to get into the technical details of it, but I will just say that there are aspects to this that are challenging, technically speaking, though we are increasingly kind of figuring out how to move around the tricuspid annulus to get where we need to go. One of the bugaboos of edge-to-edge repair in the tricuspid is that the leaflets are really thin, which means two things. One, it means they're much harder to image because they're so thin, they don't show up on echo as well. And two, it means, if you're counting on these leaflets to pull the whole annulus in by virtue of these clip devices, that can be a lot. And in fact, I'm going to get to that in a second. But in fact, if you, there is a rate of leaflet detachment that is a little higher on the tricuspid than on the mitral. So I wanted to tell one brief story, and I'm cognizant of time here, about a patient that has always just stuck with me. She was 78 when she got sent in 2016. And she had normal RV and LV function, mild to moderate TR at that time, and severe AS. And her brother was a professor at Johns Hopkins, and he came to the clinic visit. And at the time, we were enrolling in Partner 3, which is a randomized trial of surgery versus TAVR for low-risk patients. And we offered her this therapy, and they said, no way. The TAVR is too new. There's not enough data for it. We want surgery. And that's always stuck with me because she's probably the only person that's ever turned me down when we offered them TAVR. Usually it's the other way around. They're arguing for it. And so instead, she went ahead and got a Percival valve. Somewhat ironic given the lack of data on Percival. But anyway, she got a Percival valve and did very well, though had new post-op atrial fibrillation. Time goes along, and this atrial fibrillation kind of persists. First, she's rate controlled, and then, a couple years later, she gets cardioverted, amiodarone, and now her RV function is kind of quote unquote low normal, and she has severe TR. And she's referred back for progressive breathlessness and to discuss her tricuspid regurgitation. And now she's 83. And she comes to clinic and she says, I really want you to call my brother. And I was like, oh boy, I remember this guy. He was the one who told me that TAVR was too new, at 2016. Like, you really want me to talk to him about clipping your tricuspid valve? Okay, all right, let's see. So I call the professor, and by the way, he's lovely and super smart. And I get on the phone with him, and it was this Saturday morning, and I'm standing in my driveway. I remember I was talking to him, and he says, well, my sister doesn't have any edema. And I said, I agree, she doesn't. But I'll tell you anecdotally, now that we're treating tricuspid valve without tons of evidence, what we're seeing is that patients come back talking about breathing. They talk about breathing better. And I have to admit that that's surprised me over the last couple of years, because I, historically I always thought left-sided valves are breathing valves and right-sided valves are edema valves, and treating tricuspid regurgitation and getting less breathlessness is confusing, at least on the face of it. But that's realistically what we're seeing when we get a reasonable result. And he says, he basically like over the phone patted me on the head like I was a cute little boy and was like, son, I've been studying this since the 80s. We have like 3 trials on this in dogs demonstrating that of course you get less breathlessness if you treat RV, volume overload, and tricuspid regurgitation. I completely agree that this is obviously how this should go. His name is Dr. Mon. His sister's name is different, so I feel fine telling you that. And Dr. Mon basically like gave me a dissertation in RV LV coupling, and then suggested like 4 trials that we should do, and I should get a research fellow and this, that, and the other. And he said, I can't wait for you to do tricuspid clip in my system. Didn't care about the data. So there you go. Who knows? But what is the data? Well, Trilomite, which is a study of tricuspid clip, there has 6-month data for the initial compassionate use cohort, and essentially what they saw is that the more TR you start with, the harder it is to get to moderate therapy. Moderate regurg. So if you start with torrential regurg, it's much harder. This is the far left panel there. Much harder to get from torrential to moderate than it is to get from severe to moderate. There was at least a 1-grade reduction in 86% of patients, but they did have that 7% single leaflet detachment. So that's, a reflection of those thin leaflets. 5% all-cause mortality, but it's only 85 patients. So just some preliminary data. They also saw the atria and ventricles shrink, TAPSE improves, New York Heart Association class, all improves. So what about this particular patient? What did we do? Well, I'm going to let you in a little secret. I probably wouldn't have shown you a case where we didn't do a pretty good job. She went from severe TR, she got 2 clips, and post-clip she had pretty mild residual TR. And has done fairly well, though she's still struggling with her atrial fibrillation. Actually, I spoke to her the other day. Our tricuspid clipping here at UW has really kind of exploded over the last couple of years. These are just projected numbers for 2021, but it's certainly taken off, just representing the fact that this is a patient population that's largely been undertreated, and people are really enthusiastic about offering their patients something, even in the absence of definitive data. But there is a pivotal trial ongoing, which we are participating in. The Trilomite pivotal is 700 patients that is randomized 1-to-1 against medical therapy. So it should provide a lot of substantial information about how this therapy works and how intervening on the tricuspid valve itself works. Similarly, the Evoke Valve is a transcatheter valve replacement option. Initial data on this is 25 patients, which demonstrated 96% efficacy in reduction to mild or moderate or none TR. There is an 8% pacemaker rate in the early data, and there's a whole bunch of factors that we're going to have to consider for this patient population that we haven't been to date, like CT sizing, which has just not been a standard part of TR evaluation in the past. Also, this IVC to atria to tricuspid angulation and how those sort of go together will be a part of this to get the valve to sit coaxially. But we are a long-awaited Triset 2 trial. We have our site initiation visit October 27th. It will be up and running November 1 of 2021. It's like 2 years in the making. This is a randomized trial, 775 patients, 2-to-1 randomization, therapy versus optimal medical therapy. And in fact, if you're in the OMT arm, at 1 year, you can cross over to Evoke if you're still symptomatic and alive and so forth. All right, so there's a lot of opportunities here for precision around transcatheter therapies, and I'm not going to belabor this because I'm going long in the tooth here, but we're going to have to start really, if transcatheter therapies take off, which they seem to be, we're really going to have to think through long and hard, which therapy is right for which patient. This is a very simplified decision matrix, but coaptation gap and annular size are probably the two things that are easiest to understand for tricuspid valve patients. As the annular size gets too big, the valve replacement options don't work because they won't reach. As the coaptation gap gets too big, the edge-to-edge repair issues are hard because you can't pull those leaflets in. So maybe you end up with some kind of strategy like this. All right. Okay, we're here. We're almost done. Recap. TR is prevalent, and it's mostly secondary. I think there is increasingly inferential data that it is culprit, not bystander, or if it's not a culprit, it's at least accessory to the crime. The guidelines demonstrate no mortality benefit to med therapy. Treat the primary issue when you can, and you can consider surgery. That's essentially what they boil down to. Surgical therapy is very low penetrance, about a 10% 30-day mortality, and chronic heart failure is a risk factor. And lastly, transcatheter therapies are a rabbit's warren of devices, but we're finally going to be pumping out some randomized clinical trial data that can inform decision-making around this space and hopefully answer a lot of persistent questions. So with that, I'll wrap up. I'm sorry if I've run long. Thanks so much for your attention.
Thanks, Jamie. If there are questions, please raise your hand or send a note in the Q&A or chat function. Jamie, while they're starting off, can I ask you a question? So the data, I want you to answer a philosophical question about all of these devices that are coming on the market. What is the right endpoints for clinical trials? Because you showed me a slide earlier that suggested there was at least a 30% improvement in mortality at 1 year, fixing TR. That should easily be able to do a mortality trial. But then the trials you showed us that are going on have these composite endpoints that include a lot of soft outcomes. And, I think it's really hard to do sort of procedurally based randomized control, placebo controlled. There's a huge, as you know, placebo effect. And we in Canada did Weinberg procedures for many years. And so I just maybe give us your thoughts on what the right metrics should be.
Yeah, well, I agree with you. I think my interpretation of those outcome composite outcomes are that the companies are hoping for a mortality benefit and are hedging. And I would love to, I think that we should be able to find a mortality outcome if TR is in fact as saliently involved in that mortality as I believe it probably is. But even the partner trial, right, for aortic stenosis, all those trials, they also created composite outcomes, and they clearly have demonstrated mortality benefit. But when they started, they threw in the KCCQs and the 6-minute walks and all that. And some of that, I guess I will reflect on that a little bit, that a lot of these patients are, they're 87 years old or whatever. And at least in the TAVR space, they don't care necessarily about the mortality benefit. They care about living better. And so while I agree that that mortality should be an important outcome, I can appreciate why it will be important to demonstrate quality of life improvement too. And whether that should be primary outcome or secondary outcome is arguable.
We have one question, and then maybe we'll wrap up because we're a little bit over, but it came from Greg Roth. And the question is, since so many cases are due to device wire, can any of these devices improve TR around offending wire, without the wire having to be removed?
Yes is the answer. It's clearly the more wires you have across the tricuspid, the more challenging that is, of course. And some of these patients have 2 and 3 or even 4 wires in there, and abandoned wires and defibrillator wires. So the more you have there, the worse that is. And I think, I need to give Chris Patton a shout out that her lead removal program is really great, and probably will continue to grow as our understanding of the impacts of this scenario grow. But yeah, the short answer is that some of these treatment options do work even in the context of leads, and are even allowed in the trial. Not all leads, though. There are, so it's kind of case by case.
Thanks. All right. There are a number of other comments you might look at in the chat, but thank you so much, Jamie, for the presentation. Appreciate everybody staying on. Have a good weekend. Thanks all.
Thank you.